Wow, well that was a great sort of segue, I think, into what I'd like to tell you about. And it may seem like what I'm going to describe comes a little bit out of left field, but I'd like to tell you about our program on cancer and infectious disease. And what I hope you'll get out of this are some of the messages, actually, that Maura sort of brought up in terms of collaborative, multidisciplinary projects that have a major impact for foreign affairs. So I think I first have to tell you a little bit about why you should consider cancer an important global health issue. This is obviously a very savvy audience, but I think cancer is really under-recognized as a major global health problem. So just first, by way of some statistics, I think it's important to mention that cancer presently kills more people worldwide than HIV, tuberculosis, and malaria combined. But I think most people don't recognize this as a significant threat to global health. Moreover, of these deaths, about 8 million every year, 70% of these deaths due to cancer are in low and middle resource areas. So really, I think that cancer is truly a problem, a global health problem, and one in low and middle resource areas, not just in countries that are wealthy enough to afford to develop cancer. Even more surprisingly, perhaps, is that 22% of cancers around the world are attributable to a chronic infectious disease. So again, that's a statistic that takes many people by surprise. But at the Fred Hutchinson Cancer Center, which is the largest independent research organization in the United States, we've recognized that there is this link between infectious diseases and cancer, and we've begun to explore that relationship. So just by way of example, cancers such as lymphoma, stomach cancer, liver cancer, and bladder cancer, all of these are attributable to chronic infections. So one thing that's also important to recognize is that among the infection-related cancers, they're not equally distributed across the globe. So here in Washington, D.C., maybe about 10% of cancers are due to chronic infections. But in a place like sub-Saharan Africa, over 50% of cancers are due to chronic infections. So as a researcher, and that's what I spend most of my time doing at the Fred Hutchinson, again, we are looking at infections as both the cause and as a consequence of cancer. So my group has been interested in questions like, how are these infections which cause cancer acquired? How can we develop new strategies to prevent and treat cancer based on these infectious diseases? And finally, what I call the 70-to-1 paradigm. So 70% of the people in this room are infected with at least one infection that can cause cancer, but less than 1% of you will develop cancer as a consequence of that infection. So these are the research questions that we are looking at. And frankly, the best place to look at some of these questions is not in Seattle. So in 2004, I actually came across a publication in the medical literature that suggested that Uganda had the highest rates of infection-related cancers of anywhere in the world. And so the following year, I initiated a collaboration with the Uganda Cancer Institute. Now, the UCI is a very interesting organization. It was the first place anywhere in the world where it was recognized that an infection could cause cancer. There were children there. The most common cancer in children is called Burkitt's lymphoma, and this is a cancer that is due to Epstein-Barr virus, the virus that causes mono. In 1967, the U.S. National Cancer Institute founded a clinical research site at the Uganda Cancer Institute. It wasn't really the best time to do that because, unfortunately, 4 years later, Uganda sort of fell into a 20-year period of political turmoil. And unfortunately, the investments that were made at that cancer center were essentially lost. But even in that brief 4-year period, it's quite remarkable what they did. Right now, we use combination chemotherapy as the standard for how we treat cancer. And the first place anywhere in the world where combination chemotherapy was administered was in Kampala, Uganda. So really an interesting history of cancer in Uganda. So when we began our collaboration in 2004, there were a couple of other statistics that I want to share with you that are quite shocking. So Uganda is a country of 32 million people, and in that 32 million person country, there was one oncologist, one cancer specialist in the entire country, and one cancer treatment facility, which at the time had no running water or electricity. So there were real challenges. Cancer was a huge problem for the population of Uganda, and there were really no resources to deal with it. So we initially started with a research collaboration, and the research has made important advances in understanding how chronic infections lead to cancer, strategies for the prediction and prevention of cancers, new innovative tests that can determine people who are at highest risk, and new methods that we can use to actually prevent cancer before it is developed. There's been outstanding opportunities for research that have been recognized through this collaboration, and our work is actually funded by the National Institutes of Health. We have partnerships with, again, we're funded by charitable foundations such as the Doris Duke Foundation. But then also, we have recently started partnering with the private sector, so U.S. pharmaceutical companies are also recognizing that this is a very efficient and impactful place to do research in cancers in low-resource settings. So in the course of conducting these research projects, though, it became very obvious that there was more that needed to be done. We couldn't just sit there and continue to do medical research. We needed to find ways of dealing with the problems of cancer in low-resource settings. So, as an example, some of the fruits just seemed so low-hanging. For instance, this Burkitt's lymphoma, the most common cancer in children, in the United States is 95% curable. In Uganda, has a 5% one-year survival, and the cost of treating a child is $535. So it's clearly a good investment, but yet it was something that is almost impossible for most of the kids. So we really did try to develop a collaborative program to work on this issue of dealing with better medical research and better strategies for managing cancer in low-resource settings. I should point out that this focus on cancer in low-resource settings has implications that are unique even to us here in the United States. In Seattle, our public hospitals have essentially become a low-resource setting, and the concept of spending $100,000 on a chemotherapy regimen that extends life by 3 weeks is no longer feasible. So we really need to look at ways to provide cancer care more efficiently, and one way of doing that is working in low-resource settings. So what do we do to try and build capacity to deal with cancer care and cancer research? Well, essentially our program has a 3-legged stool. We work on medical research, we work on training and capacity building, and we work on improving clinical care. So we started a training program. At the Fred Hutchinson, we have a world-renowned program which trains cancer physicians, and in the last 2 years alone, we've quadrupled the number of cancer physicians in Uganda. That's not as adventurous as it sounds, because we only had to add 3 back to the Ugandan population. But they are now back and working in Uganda, and the expansion in the ability to handle patients with cancer is quite remarkable. That single cancer doctor was seeing 10,000 patients a year, which I can tell you as a practicing physician is just inconceivable. So now we've expanded our training program, and we've now trained, just in the last 3 years alone, 50 individuals, both from the US and from Uganda, at many different levels for medical research and medical care. And this has really allowed for an incredible expansion in medical research and care delivery in Uganda. Beyond that, I think we needed capacity to deal with this at a physical level as well. As I mentioned, the Uganda Cancer Institute was in no shape to sort of meet the challenge of cancer in a low-resource setting. And so it was actually a grant from USAID, from their American Schools and Hospitals Abroad program, that allowed us to start the construction of a new training and clinical care facility. And again, we hope that this will be a flagship model for developing new ways to deal with cancer in sub-Saharan Africa and other low-resource settings. So I guess how does all of this speak to the questions that we're all sort of here trying to address, which is really how can medical research and care help us meet our foreign policy and foreign assistance goals? Well, I think we have a unique vantage point to answer that question working in Uganda. Unfortunately, many of you may have seen the news several weeks ago where there were 2 bombings in Kampala set off at the end of the World Cup, where 74 people were killed. And these bombs were ostensibly placed because of Uganda's involvement as part of the African Union peacekeeping mission in Somalia. Clearly, to the US, that is a very high-value mission, that peacekeeping mission in Somalia. At the same time, Uganda serves as the base of operations for the UN peacekeeping missions in Darfur and Southern Sudan. So really, having a strategic partnership between the United States and Uganda is very important. But what is the role of foreign assistance in terms of medical research and medical care in this sort of connection? And what I would say is that I've really seen firsthand how illness destabilizes a society. And in Uganda, I think that there's several examples I can provide of that. The most common cancer is Kaposi sarcoma. It's a cancer which the average age of onset is about 29 years of age. And so you take a person in their peak period of productivity and essentially you render them useless to society. But more than that, the care, even trying to pursue care for this cancer bankrupts them and their family. Similarly, the most common cancer in kids occurs at the age of 5, and the resources, the years of life lost for dealing with that is really enormous. But so things like this really do quite a bit to destabilize society. And if you're looking for an example of how just foreign assistance can change that, I think you don't have to look much farther than the PEPFAR program. And in Uganda, the US government spends about $250 million a year supporting HIV care models. And there have been study after study which have shown how this has strengthened the Ugandan society. So really, this foreign assistance program has been incredibly successful in Kampala. But the question is, how do you extend this beyond HIV? So I have a couple of thoughts, and I'll just leave you with these. I would say that first, it's really essential that we have coordinated multidisciplinary efforts that really add value in low-resource settings. And I think that our program is a good example of this. So we have US and Ugandan federal stakeholders that sort of are working with us. We partner directly with the Ugandan institution and the Ministry of Health. But we also have public-private partnerships. So our funding comes from public sources in the United States, but also private sources. And we can use these funds in different ways. Funds from NIH are mandated only to go to research. Funds from USAID are actually mandated only to go to care. But by sort of cobbling these things together, adding charitable donations, we're actually able to establish a multidisciplinary program that's both sustainable and highly impactful. And I think that as President Obama introduces the Global Health Initiative, we really will see an expansion of foreign assistance to non-communicable diseases, and those with a focus on children and the family. I think that we really have some opportunities here to make meaningful differences. So I guess what I would say is that really we find ourselves at a very propitious time to sort of consider how we can change our foreign policy goals and our foreign assistance goals to catalyze medical research and medical care in ways that stabilize societies, make strong strategic partnerships, and at the same time make important findings for global health worldwide.